question, please raise your hand or just put it in the chat and Dr. Zaid will have a look at it and raise it up with me, and we can have an extensive discussion also at the end of the lecture. I was asked to come up with a series to cover the endocrine aspect of hypertension. So I think this will cover maybe 4 or 5, even maybe 6 lectures. We're starting with the most common and most relevant to the general physician, which is primary hyperaldosteronism. We'll talk about it probably in 2 to 3 lectures. At the moment, I have planned 2 lectures for primary hyperaldo. And then we'll have some discussions about PHEOs and the proper testing strategies. Of course, some of these are beyond the scope of the general physician, like the management of PHEOs, but at least we'll discuss the diagnostic part, because PHEOs come up very frequently as a referral, but they're rarely true. And then we'll end up with some Cushing. Some of the information provided in these series would be more relevant to those of you who are interested in pursuing a career in endocrinology, but they'll also be very useful for the general physician. I didn't put a lot of details, and I tried to keep it as practical as possible. So I hope you enjoyed and you learned something from it. So today we'll start with the primary hyperaldo. I remember when I was doing my medical school years, there was a Davidson textbook and Kumar and Clark, and that was maybe almost 20 years ago when I think about it. What year? Yes, 2004 maybe, yes, 5. They mentioned that hyperaldo will constitute maybe less than 1%. And we know that this is not true. This is absolutely wrong. Primary hyperaldo is a very common cause of hypertension. Up to 5 to 10% of all hypertensives. And in those that you usually see and that I usually get referred, those who require 3 or more drugs, the percentage actually goes up even higher, 20 to 50%. It is more common than coarctation. It is more common than PHEOs. It is more common than Cushing. All these things, I would probably say most of the secondary hypertension is either renal or primary hyperaldo. So these are the 2 things you need to remember in your mind. Now, in patients who have primary hyperaldo, we know that this is quite common in those who have hypertension and have obstructive sleep apnea. So now when I see somebody who has a large neck circumference, a high stop bang score in my diabetes clinic, and uncontrolled blood pressure, I definitely think of hyperaldo, and I just send him for aldosterone and renin, and we'll go through that in details. Some unusual presentation is when you dig into the details. Today I had 1 patient with primary hyperaldo. When you dig into the questions, they will tell you they usually have some paresthesia, some numbness, some muscle cramps from the low potassium, from the alkalosis, which causes some ionic hypocalcemia. Now, very rarely, about 3 weeks ago, I got referred a case from a colleague in Iraq. A very interesting 45-year-old was referred for a diabetologist for newly diagnosed type 2 diabetes. And then all of a sudden, her CK is 30,000 with very low potassium. And when we investigated her, it turned out to be primary hyperaldosteronism due to an adenoma. These are rare presentations, but you should always think about it when you have some low potassium, muscle aches, and high blood pressure. Now, the classical hypokalemia, I need you to be aware of this. This is very important because people think, oh, potassium is normal. This is not hyperaldosteronism. And this is absolutely wrong. Hypokalemia is only seen in less than 1/3 of patients who have primary hyperaldo. And when you see it, whether it's spontaneous or whether it's thiazide-induced, you need always to exclude primary hyperaldosteronism as a cause of hypertension. I've seen it before. Oh, this is just the thiazide causing low potassium and a poorly controlled blood pressure. Thiazides don't cause low potassium in patients who have high blood pressure, unless there is something else going on. It's if someone who has treated a lot of hypertension, you don't see hypokalemia in patients on TED unless there is something else going on, either combination with furosemide or there is hyperaldosteronism. So why this is important? If we're going to treat it in with medication, why this is important to recognize? It's very important to understand it is not the blood pressure alone that is the problem. No, people who have high aldosterone are at higher risk of ischemic heart disease, angina and heart failure, higher risk of AF, higher risk of stroke, even if you control their blood pressure, unless you control their aldosterone. And we'll come to that in detail next. So I want you to understand it is not only the blood pressure that you need to control in these patients, and that's why it's important to recognize and diagnose it. So we'll go through some physiology just to refresh your memories. And so this is taken from a lecture that was given 2 days ago by one of our leaders in endocrinology and primary hyperaldosteronism, Dr. Mark Carnell. He works in Cambridge, and it's very interesting to see why it's a problem. So if we go through the curve, let me see if I can get the pointer here. Yes. So what happens normally is, so we have the renin, which is the system and the kidney, and the glomerular densa and the glomeruli, which basically detects the sodium in the tubule. So if you have low sodium in the tubule, or if you have hypovolemia, which also ultimately results in low sodium in the tube, renin becomes stimulated and it tries to converts angiotensin 1 into angiotensin 2, and then angiotensin 2 goes to the adrenals and results in increased production of aldosterone, which goes back to the kidney, as you can see here in the distal tubule. What it does is through this ENaC tubule, it reabsorbs the sodium and excretes the potassium. And at the same time, it also excretes the H. And that's why you get the classical picture of low potassium, metabolic alkalosis, and hypernatremia, or sodium in the upper limit of normal range in the blood. Why this is important? Because by the end of the lecture, when I will end with what I treat or how I treat it, we will see how this is relevant. Because, for example, here you can use amiloride, which blocks this channel, which is a very good drug. Or you can use spironolactone, which actually blocks the synthesis or the effect of the aldosterone, and you can achieve very good results. Now, you need to understand that aldosterone, if it is high, it suppresses renin, okay? And we have two types of hyperaldosteronism. We have the primary or the secondary. Now, the primary means, and I need you to understand this very well, primary means that the aldosterone is primarily being produced from the adrenal glands, okay, without stimulation of renin, okay? So this is very, very important. While secondary means it's becoming increasing due to an effect of renin. And how do we know this? If the renin is normal or high and the aldosterone is very high, it means that the whole process is driven by renin. It's like TSH and T4. But if the aldosterone is high, the renin will be low in a primary hyperaldosteronism. So if you want to think about it like this, what happens in hyperthyroidism or a primary hyperthyroidism? The T4 goes up, the TSH goes down. Same thing here. Aldosterone is like T4 and the renin is like TSH. This way you'll be able to make sense of it. If the TSH is normal or high and the T4 is high, as you remember from the thyroid lectures, we think that this is probably a secondary hypothyroidism. And the same thing here. If the renin is normal or upper normal or high, and the aldosterone is high, it means that this is secondary hyperaldosteronism. And I'm not usually interested in that. This goes to the nephrologist, okay? If the renin is suppressed or low with even a normal aldosterone and a high blood pressure, then this is a primary hyperaldosteronism, okay? Now, it is very important to understand that the production of aldosterone is potassium dependent, as you can see here. So if the potassium is low before you test, it's going to mess up your testing because low potassium will suppress renin. All right. So you need to make sure that the potassium is always normal, at least 4 and above, before you test for aldosterone and renin. What are the consequences of all this? All the consequences that you will have a mineralocorticoid receptor activated because the mineralocorticoid receptor binds to the aldosterone. And where do we find this? We find this in the adipose tissue. And that's why, for instance, we get diabetes. We find it in the muscles, and that's why you get myopathy. We find this in the kidneys, and that's why you get hypokalemia, high bicarbonate, and high sodium. You also have it in the blood vessels, and that's why you get hypertension. The interesting thing is it's also present in the CNS, and that's why these people inadvertently, they crave salt. They want to eat more salt, and that only makes it worse. They like salt more than normal hypertensive. So if you have somebody attending you and you ask him, do you eat a lot of salt? He'll tell you, yes. Oh, I eat a lot of salt. I like salt. I can't stop eating salt. This means it's probably he has hyperaldosteronism. It's like people who have iron deficiency who like to eat rock. Any questions for now شباب؟ أي سؤال عندكم على هاي الفيزيولوجي اللي تكلمنا عليها؟ ماكو سؤال. زيد أنا شوية ما أتابع الشات فأنت
اي نعم استاذ ياسر رحمه الله.
اي تابع لي الشات الله يحفظك.
نعم.
Good. So we come to the next step. You suspect it, you want to test for it. قلنا who do you suspect it? People who require 3 or more, people who have low potassium, people who have hypertension and adrenal adenoma, people who have family history of hypertension and intracranial hemorrhage. All of these people who have obstructive sleep apnea. I usually test everybody because I'm very comfortable in interpreting these results. It's part of my screening strategy for patients who have hypertension. Remember, what are the investigations you need to test? You have to check for calcium to rule out PTH. I don't know. You have to check for thyroid. This is routine for everybody with hypertension. For me, I always send aldosterone, at least aldosterone, and I'll tell you why. Now, how do we screen for it? So I keep it very simple. There is something called case detection testing. What do we mean by case detection strategy? It simply means we do a test just to roll patients in, and if it is negative, it's negative. I don't have to worry about it. It's a screening test that you need to do almost for everyone who has difficult to control high blood pressure. What do? You request aldosterone and renin. Now, in Iraq, I know that there's a problem with the renin assay, but more recently, it's become more widely available. But what you can do, you can always just at least send an aldosterone. If the aldosterone is more than 10, because aldosterone assays are more standardized and it can give you an idea. But generally, of course, ideally, you want the aldosterone and renin and electrolytes requested because it's like requesting a TFT. You want to understand what's causing what. You want to understand the whole pathway, the relationship together. But if you can't do that, then you just at least send for aldosterone as a screening test. And if it is above 10 nanogram per deciliter, and these are the numbers that we use in Iraq. So I put these numbers just for you. Here we use different numbers in the UK, but it's the same. These are the American numbers. They're very standardized and even better than the picomole per liter. But if the aldosterone is more than 10, then you need to screen for primary hyperaldosteronism details. These are the numbers that I want you to remember. More than 10, more than 20, more than 30. And I'll come to that in details. What does it mean to have more than 10? What does it mean to have more than 20? And what does it mean to have more than 30? Now, primary aldosteronism should always be suspected if the renin is suppressed less than 1. This is what we call plasma renin activity. Now, you need to understand that we measure the renin in 2 ways. We either measure the activity of the enzyme or we measure the level of the plasma renin concentration. Okay. So the plasma renin concentration, this is the assay that we have here in Iraq, guys. Okay. So if it is less than 8, it means that the levels is suppressed. All right. Remember this number. If the PRC or the plasma renin concentration, because this is the assay that we have in Iraq, if it is less than 8, it means that the aldosterone is suppressing the renin. All right. And if the plasma aldosterone is more than 10, then this is primary hyperaldo, and you need to confirm it. So first you go for case detection, and then you confirm it by requesting saline suppression testing. Why do we do this? Because not all hyperaldosteronism is due to an adenoma or hyperplasia. If it is suppressible by giving the patient saline, basically you're giving salt and water. If it suppresses the aldosterone, it indicates that this is not a spontaneous hyperaldosteronism. And if it is suppressible, you need to look for other causes. If it is not suppressible and the aldosterone remains high, then you need to go and do what we call subtyping. So 3 steps: case detection, confirmation, and then subtyping. Subtyping means what kind of hyperaldosteronism I'm dealing with. So this is a summary from the guidelines, and it's very practical. This is the most practical that you can find. So you go for case detection. I'm repeating this because this is what you are going to do in your practice. You test for aldosterone concentration, and we said, remember the number more than 10. Okay, more than 10 is unlikely to be false positive. And you check the PRC. Don't worry about this number. Don't remember this number because we don't have it in Iraq. We have this number. So if the aldosterone is more than 10 and the plasma concentration of renin is less than 8, then you have a positive secreting test. You need to confirm it by using the saline suppression testing. There are other ways, like sometimes we use the sodium loading for 4 days, but I prefer the saline infusion test. You give 1 liter over 4 hours, and then you measure the aldosterone after that. If it remains high or even more than specific number, it differs on your assay, but generally, if you're using the picomole, it's more than 200, 230, it is a positive. But basically, if it remains normal and not suppressible, it means that there is primary hyperaldo, because if you receive 1 liter of saline, your aldosterone should drop. So this is the same thing here. I don't use the urinary aldosterone because it's difficult for patient to collect it. I just use the plasma aldosterone after the 4-hour saline. Now, what does that tell you? If you confirm it, then you have primary hyperaldosteronism. And then you need to know what is causing this. So it could be one adenoma, it could be bilateral adenoma, it could be hyperplasia, it could be hyperplasia and adenoma, all of these things. So what you do, you go for CT scan or imaging, and you go for adrenal venous sampling. And I'll tell you when do you need to do each step of these. So if you remember, I just told you, remember 3 numbers, 10, 20, and 30. If you have an aldosterone that is more than 20 and hypokalemia, you don't need to do the confirmatory testing. It's already very high. You don't need to do it. And if you have a plasma aldosterone more than 30 with hypokalemia, and the age is less than 35, and adenoma is present on the scan, then you can go ahead and do the surgery without doing adrenal venous sampling. What is the meaning of adrenal venous sampling, guys? Guys, it's very important to understand. If you just follow the imaging, you will do a lot of mistakes. You will remove incidentalomas, especially in people above the age of 40. It might be difficult to prevent yourself from sending the patient to surgeons. And it's very unfortunate if the patient sees the surgeon first, because they, oh, okay, you have adenoma, you have hyperaldosteronism, I'll take it out and everything should be fine. But this is not the case. Unfortunately, we have a lot of an incidental finding, and you might end up removing an incidentaloma and keeping the patient with hyperaldosteronism on the other side. And adrenal venous sampling, you go, you enter, you measure the aldosterone on both sides. and you decide whether the aldosterone is coming from the right, from the left, or from both sides, regardless of what the imaging is saying to you. Is there any alternative? Yes. Now, unfortunately, we don't have adrenal venous sampling in Iraq, but there is an alternative, which is becoming more and more fashionable these days. It's called the metomidate PET scan. It's been widely used now in Cambridge. I'm not sure if it is
تعال بابا
available.
تعال
Sorry,
ممكن يشغل هذا
Zaid, من فضلك كده ممكن if you can mute the other
Yeah, no,
participant.
no,
Yes,
no, sir.
thank you. I was talking about the PET scan here. So the PET scan has a role. It's called functional imaging. They use a special tracer. It's called etomidate or metomidate, which is concentrated in the specifically in the hyperaldosteronism adenoma. So it can tell you on the imaging without needing AVS whether the aldosterone is coming from the right, the left, or both sides. And we will show you, I'll show you later on some of the interesting images. This table is for you to understand what do we mean by subtyping and why it is important. Now, in most of the cases, there's an aldosterone producing adenoma, okay, in 30% of the cases. In most of the cases, apologies, it's bilateral coming from both sides. It can also be a unilateral adenoma on one side and another adenoma producing cortisol, or it could be anything. And very rarely seen in ACC or adrenal carcinoma. This is the primary aldo. There is subtyping, there's familial type. If you have a family history of it, the most frequently seen in the exams is the GRA or the FHH type 1. It comes up as a scenario in the board exams as a patient who presents with high blood pressure, low potassium, hyperaldosteronism, that kind of thing. But they will mention to you that there is a family history of intracranial hemorrhage. I had one case like that in Baghdad. Now, this happens because the mutations binds the CYP11B1 and CYP11 beta 2, which basically means that your aldosterone will become stimulated by ACTH and you'll get hyperaldosteronism. Normally, the ACTH does not stimulate the aldosterone, it only stimulate the first step in the synthesis of aldosterone. But when you have a mutation in this chimeric gene, combined gene, it combines the stimulation. So the CYP11 beta 1 will be stimulated by the ACTH, and you'll get hyperaldosteronism, which responds to steroids, because when you give the dexamethasone to these patients, it suppresses the ACTH. And then ultimately, no ACTH, no aldosterone, and the blood pressure will improve. I hope this makes sense to you. When do you suspect this? If you have a patient who has hyperaldosteronism less than the age of 40, you have to send for genetic testing for all of these. Now, this is just a summary of the
أستاذ
journey.
أكو
Yes.
رسالة أكو كومنت من أستاذ رافت.
أكيد بس لحظة دحين آسف مين أشوفها المشكلة ممكن تقرأ لي إياها زيد لأنه أنا بس عندي السكرين شير فما يطلع عندي الشات.
نعم العفو أستاذ رافت طويل طبعا يسلم عليك. هاي راز نايس تو
السلام
سي
عليكم مرحبا أستاذ. مشتاق لك كثيرا.
السلام
أعرف ذاتي
عليكم.
صراحة.
عليكم السلام أستاذ رافد، مشتاق لك كثيرا والله.
مشتاق لك جدا حبيبي، سعيد بشوفتك.
أكيد أنا هم.
ايه حبيبي ما اطول عليك، هالسؤال راح يقرا لك اياه دكتور زيد، نشوفك ان شاء الله.
شكرا.
What are the
Yes.
what are the co-founder conditions or drugs that affect the screening for renin and aldosterone, and for how long we should withstand them before the screening test?
Well, thank you very much. This is a very common question, a very important question. If you ask me, the only thing that I would consider holding is the spironolactone. That's the first tier. So spironolactone, eplerenone, and hypokalemia, I need these to be corrected. يعني على المستوى الأول هو السبايرو eplerenone. طبعا what I normally do is I screen everybody. So if I have a patient who is on spiro, I do the aldosterone and renin. If the renin is suppressed, that's it. I'm happy enough that this patient has hyperaldosteronism. Because if the patient has suppressed renin while he's on spiro, it means that the spiro is not enough and he has already primary hyperaldosteronism. But if the renin is high or unsuppressed in patients who are on spironolactone, and I suspect that they have hyperaldosteronism. For example, you have a patient referred to you who has hypertension, who was found to have hypokalemia and was started by spironolactone by a colleague. Common scenario. So when the patient arrives to you, what do? I screen them. If the renin is unsuppressed, which means above 8 in the assay that we use in Iraq, then I'll have to stop it for at least 2 weeks, preferably 4 weeks. Okay? But if I cannot, I'll stop it for 2 weeks. In the meantime, I'll put the patient on doxazosin and up-titrate the dose up to 16 milligram, or you can use hydralazine, or you can use verapamil. All of these, they don't interfere. Eplerenone, the same story. The second tier of testing, the second drug that you want to avoid, ideally, is the beta blockers and thiazides. You want the patient to be off of them for at least 2 weeks, preferably 4 weeks. And in the meantime, for example, if you have a patient on beta blocker, what I normally do in my practice, and I think the patient needs the beta blocker, I change him to verapamil, okay, because this does not, or diltiazem, because these do not interfere with the aldosterone. No. And I stop the thiazide as well for about 2 weeks. Now, the guidelines usually say 4 weeks, but I usually do 2 weeks is more than enough. What I don't normally stop is the ACE inhibitors, although they might interfere, but very minimal. If I have to stop them, just 1-2 weeks is enough. And but that's only in cases when I really suspect primary hyperaldosteronism and I measure the aldosterone and the aldosterone is not that high. Because when you think about it, what would happen is all of these interferences would most likely cause a false negative screening test. If you have an aldosterone more than 10, it's very unlikely to be a false positive. That's what I need you to remember. Even if the patient on whatever treatment, I don't care. If the renin is suppressed and the aldosterone is more than 10, I don't care what the medications are. This patient has primary hyperaldo. I'll go for the confirmatory testing. So I hope I answered that question as simply as I can. So going through the journey of hyperaldo, people thought before that hyperaldosteronism is either an adenoma or hyperplasia, but we now know it is probably a spectrum. In many cases, it starts in one gland and then it appears on the other gland later on many years along the way. And although, for instance, you have confirmed an aldosterone production from one side through the adrenal venous sampling or through PET scan, and you go and you remove the adrenal gland and everything is fine, the other adrenals might in the future show autonomous production, especially if the histopathology does not show an adenoma and it shows a hyperplasia. I guess what I'm trying to say here that it is not a perfect thing. So this is the journey. First, you confirm the diagnosis, and then some centers, especially in Cambridge now, are going for early PET scan, okay? Right up front, because as you can see in that picture here, let me see if I can. So as you can see in PET scan, it just lights up very nicely here, as you can see down. So this is an adenoma here. Could be hyperplasia, but this is most keeping with adenoma. And this avoids all this thing here along the way. Now, some people just do it after the CT or the MRI, which is usually the next step. If the CT shows an adenoma of more than 1 centimeter, and you have an aldosterone more than 30, remember we said 10, 20, and 30. 10 is the positive screening, 20, there is no need to confirm, 30, there is no need for AVS. If the patient is less than 35, years of age, and there is a clear adenoma on the CT scan. You can proceed directly to surgery. Otherwise, you will definitely, classically, you'll need the adrenal venous sampling, and you can see a picture here. So this actually shows that so CT scan shows a bit of a nodule here and hyperplasia on the other side. And we go and cannulate the right and the left adrenal veins and then measure the aldosterone and cortisol levels in both sides. And I'll take you through the details of how to interpret that, but I think it's a bit beyond the scope for general medicine. But I'll just give you an idea because it's very interesting to understand what's really going on. And once you have a confirmed hyperaldo or excess aldosterone from one side, then you go ahead and you just do laparoscopic adrenalectomy, and hopefully that can get you all sorted out. Now, we will start with some cases, and I hope you find them interesting. Now, I have only included 2 cases here. One of them, when you have an adenoma on one side, the second when you have bilateral problem. And we'll take you through all the caveats here, but I would really appreciate your input here. Let me try to get this chat sorted out. Why do I don't have the chat here? هسه شفت. Okay, so I have a look at the chat now. واحد عنده شيء, you can share to the chat. Or if you want to talk, I'm more than happy. So the first case is a 35-year-old. All of these are real cases, by the way. With a 4-year history of high blood pressure, hypertension. When he came, he was on a clonidine and calcium channel blocker, amlodipine, and angiotensin receptor blocker, valsartan. And his blood pressure was very well controlled on these 3 agents. But the problem was that this man had severe hypokalemia requiring IV, multiple admissions to the hospital, and he was already on 80 milliequivalent of potassium at home just to keep his potassium in the lower end of normal. On physical examination, he was not cushingoid and he had negative family history of hypertension. So we definitely know he's young. Sorry, he has hypokalemia and he has hypertension. May shrub erixus. So we know this is probably something going on. So at this stage, what would you consider to do for this gentleman? If you can just share it with the chat or share or just talk through it, I'll be more than happy, guys. What would you do for this man at this stage? أكو خيارات. ممكن you do this screening, or you want to stop some medications, change some medications, do a scan. What would you do? So Muhammad Sardar caused PAC test. So this, Muhammad, you mean plasma aldosterone concentration? Fair enough. Okay. Anybody else who has another suggestion? ايش راح تطلب له تحاليل؟ هذا سؤالي. جات لي العيادة. وش وقت راح تسوي؟ Yes.
I'll need to measure the serum potassium at first. First, then to replenish with the and supplement the patient with the potassium before measuring the aldosterone level.
Good. So very good. So you want to correct his potassium. So his potassium is 4. That's good. He's on replacement of potassium. How would you screen him for aldosterone reading problem? What would you do? What would you tell the patient? شو راح تقول له المريض؟ تعال شو وقت تسوي؟ شو وقت تسوي؟ شو تقول له؟ هاك روح سوي التحليل وعاتن جاك العيادة الساعة 5 العصر. Mustafa suggests plasma renin concentration and plasma aldosterone concentration. صحيح. زيد يقول early morning. صحيح. All of your suggestions are correct. Now you need to know that the best time to check for plasma aldosterone is usually early morning. The patient has to be ambulatory for at least 30 minutes. المريض لازم قاعد قبل فد ساعة ساعتين ومتمشي في نص ساعة قبل ما يجيك، يكون قاعد في ربع ساعة قبل ما تسحب له. طبعا usually what we do is we do a sitting rather than a supine. There has been some suggestions that it can differentiate between the adenoma and the hyperplasia, but I don't believe it. But generally, you need to make sure that it is done in the morning. And of course, you have to know the lab. إنه ضروري جدا إنه تروح لابو المختبر وتقول له اعطيني المانيوال مال التحليل، أريد أشوف إيش قد النورمال، وتشوف الوحدات وتوحدها ويا هاي الوحدات، وتشوف إيش قد الألدوستيرون رينين ريشيو اللي تعتبر عالية. أوكي، لأن تختلف من وحدة إلى وحدة. لكن what I need you to understand is this: if the renin is suppressed and the aldosterone is high, هذا معناته primary hyperaldosteronism، ما له علاقة بالأرقام. Doesn't matter. Okay. Now you read that the guidelines say different thing, but this is all just for standardization of process. If you know your physiology, it's very similar to somebody who has high T4 and low TSH. It doesn't really matter how high the T4 is or how low the TSH is. It's mostly, this is a primary hyperthyroidism. Now, whether you need a confirmatory test or not, or whether you need to do ABS or not, this does rely on the levels of aldosterone. Shabab, okay? But for telling that this patient has a high suspicion of primary hyperaldosteronism, you only need plasma aldosterone concentration and plasma renin concentration. That's it. And that can sometimes be more than enough in most of the cases, often in elderly people who are not for surgery. You just need to know, I want to put this patient on spironolactone or not. And if I do that, what will I monitor? Because as you will learn, we don't only monitor the blood pressure in these patients. Then, so what we did is this. I'll share with you the results of investigations. Sodium 142, potassium 4.1, creatinine 1.2, aldosterone 54 عالي أكثر من 10، plasma renin suppressed أقل من 1 يعني أقل من 8 DRC، DHEAS 290، 1 ملغ دي اس تي أقل من 1. هسه واحد ممكن يسألني يقول لي دكتور أنت شو مسوي بال 1 ملغ دي اس تي أو 2 ملغ دي اس تي أو DHEAS؟ What is the role of this? Now I need you to understand that we do this usually to exclude autonomous cortisol secretion. Screening test for Cushing in all of these patients, or even if the patient doesn't have Cushing, it is not to detect Cushing, but usually if you do a scan and you find an adenoma, you have to rule out this because this is very common. Now, this is not Cushing. Autonomous cortisol secretion, or what we used to call subclinical Cushing, the term has changed recently, is not Cushing. It does not go to become Cushing disease. No, the levels remain low, but they are above the normal, and patients can present with the metabolic complications like diabetes, hypertension, osteoporosis, obesity. And we might actually do surgery for them sometimes if there's a significant adenoma on the scan. The other way to test for this is that we do the DHEAS, or dihydroepiandrosterone, which Billy Young, the international leader in aldosteronism and Cushing, calls it the HbA1c of the adrenal gland. So the DHEAS with the S, guys, not the DHEA. The DHEAS is an ACTH dependent hormone. It gives you an idea about the ACTH. So if you have any autonomous cortisol secretion from the adrenal gland, it will affect the ACTH, and you will expect the DHEAS to be low or suppressed. So if the patient has normal DHEAS, and I know that this patient doesn't have autonomous cortisol secretions, okay? So this is why we screen for this test. Now, we did the scan, okay?
العفو دكتور، إذا ممكن إعادة هاي النقطة الأخيرة لأن شوي صار تقطيع بالصوت.
Okay, I was talking
DHEAS.
about DHEAS. So, Shabab, DHEAS is an adrenal androgen. واضحة هاي؟ It is produced by ACTH stimulation. معناه if you don't have ACTH, or if you have low ACTH, you will have low DHEAS. واضحة هاي؟ if the patient has autonomous cortisol secretion. يعني شنو معناته؟ معناته عنده excess cortisol ده يطلع من الادينوما، لانه هاي الادينوما اللي هي ممكن تفرز الدوستيرون، ممكن كل شيء ما تفرز، ممكن انسيدنتلوما اللي راح تطلع عندي بالسي تي سكان. Most commonly, the most common hormonal abnormality in these patients is autonomous cortisol secretion. أرقام حتى up to 50%. It produces some extra cortisol. Not to the level to cause Cushing, not to the level of causing Cushing adenoma. No, this is different. This mild autonomous cortisol secretion can cause diabetes, worsening in the control of diabetes, obesity, osteoporosis, that kind of thing. But if is cortisol coming from the adrenal gland, it will suppress your ACTH. So the DHEAS will be low. Okay. So if the DHEAS is normal, it tells you that there is normal ACTH, and it tells you that there is no excess cortisol coming from the adrenal gland. Now, this test is also very useful for other things. If you have somebody who you suspect has adrenal insufficiency, especially if secondary adrenal insufficiency, and you don't know, you just send DHEAS. If the DHEAS is normal, then this means that this patient does not have adrenal insufficiency. So a normal DHEAS rules out adrenal insufficiency. A low DHEAS doesn't prove adrenal insufficiency. شباب مو بعدين تفهموني خطأ. رجاء انتبهوا على هاي النقطة. A normal DHEAS rules out adrenal insufficiency. يعني if you have normal DHEAS, you don't have adrenal insufficiency. I don't care what the cortisol is. So I said, it's a discussion for a different lecture. But if you have low DHEAS, you could have adrenal insufficiency. It could be aging, it could be stress, it could be anything. I don't know. Like normal DHEAS rules out cortisol deficiency, rules out cortisol excess from the adrenal gland. If you have ACTH dependent Cushing, on the other hand, the DHEAS will be on the higher side, by the way. واضحة زيد؟
واضح أستاذ عشيتكم. شكرا.
So if somebody is wondering why we do these here, this is the reason. Now, if you have excess cortisol, it affects your adrenal venous sampling sometimes, and you will see it in the next case, because I'll talk about it next. But generally, we standardize the aldosterone level in the venous sample from the adrenal glands by measuring the cortisol. So if you have cortisol, an extra from one gland, that can interfere with the ratios. But this is a bit beyond the scope of this lecture. So we did the CT scan, simple CT scan, مثل ما تشوفون. It is not rocket science. So this is the two limbs of the adrenal glands, and there is a big adenoma, a lipid poor adenoma from the left limb of the right adrenal gland. هذا liver شباب. This is the liver, all right. And this is the adrenal gland. It comes like a limb. Now, I always also look at the other adrenal glands if it is enlarged or suppressed, and I'll tell you why. So this is another scan. As you can see, this is the normal adrenal on the other side. And this is the adrenal gland on the right side. This is the right limb, and this is the left limb, other trunk. So there is an adenoma. It looks benign لأنه hypodense, وقاسون الهاوس فيلد unit أقل من 10. إن شاء الله يصير عندنا lecture على adenomas or how do you manage them, and very common now in CT scans. Everybody's getting CT scans, so you'll get a lot of adenomas. We'll talk about them, inshallah. But this is a lipid poor adenoma, so it doesn't look malignant. It's benign. It's on one side. نرجع للمريض مالتنا بس عمود الداتا. قلنا عمره 35 سنة شباب. Okay. عنده severe primary hyperaldo with hypokalemia. Okay. الالدوستيرون level مالته 50 أو 54. والسي تي سكان طلع أدنوم. سؤال: what would you do next؟ طبعا محتاج confirmatory testing لأنه الالدوستيرون level مالته أكثر من 20 وعنده spontaneous hypokalemia. سؤال: يحتاج adrenal venous sampling لو لا؟ الدكتور زايد والدكتور محمد they both suggest surgery resection. Good. Good. So this is a case. This is the rare. This is the unusual when you don't need the ABS. I agree with all of your decisions. Thank you very much. So we sent this patient to surgery on the basis that this patient has primary hyperaldosteronism, severe primary hyperaldosteronism, and I repeat, with an aldosterone level more than 30 nanogram per deciliter, with a profound spontaneous low potassium, and on the top of that, a very obvious clear adenoma that is more than 1 centimeter present on the scan, and the age of the patient is 35. لو عمره 40 لا حول ABS. Okay. Now, until this stage, you need to follow that patient. So this is the adenoma, as you can see, very yellow, coming out from the right limb, the left limb of the right adrenal gland. فمثل ما ناقشنا إنه all of these makes it probable that this is an adenoma. طبعا إذا تلقي ال other side بhyperplasia أو بnodule أو looks abnormal أو enlarged، هذا الكلام بعد ما يصح. هذا كله معتمد على أنه the other adrenal glands مثل ما شفناها هنا as we saw it here in the previous slides looks completely normal. Okay. If there is any abnormality on the scan of the other adrenal glands, then you need to consider something else. So this is an example of a classical hyperaldosteronism presenting with hypertension, severe hyperaldosteronism with spontaneous hypokalemia when you don't need to do the adrenal venous sampling. Okay. سؤال يقول, does this severe hyperaldo present with normal? Absolutely, yes, of course, of course. Patients with hyperaldosteronism are not necessarily hypertensive. It could be due to multiple factors. They could be developing some features of heart failure. Their medications could be very high. But the fact that they have hypertension that requires 3 or more medications is an indication to screen, especially if they have hypokalemia. So the control of the blood pressure in itself, it doesn't tell you. Of course, you would expect to be uncontrolled, but not always. So not always. But having a controlled blood pressure on 3 or more agents does not mean that you don't screen the patient for hyperaldosteronism, especially if they have other risk factors like obstructive sleep apnea or hypokalemia. So I'll move on to the next case. Now, the next case we will discuss bilateral nodules. So our next patient is a 69-year-old African man, 15-year history of hypertension, treated with 3-drug program, beta blockers, vasodilators, hydralazine, and angiotensin converting angiotensin receptor blocker, which is losartan. Blood pressure control was not optimal, with a systolic blood pressure in the 150s, with a spontaneous hypokalemia, with a potassium of 3.2, 3.1, but remarkably, he was never tested for primary aldosteronism until recently. So we did the usual testing. So I'll be very keen for any of the attendants just to comment. So his sodium on that day was 146, potassium 4.5, creatinine 1.6, EGFR 52, so chronic kidney disease stage 3A, aldo 71, renin fully suppressed, DHEAS 37 on the lower side. So be careful, this is on the lower side. ACTH is 12, 2 milligram dexamethasone suppression test is 2.6. Now somebody will say, why use 2 milligram? So usually use 1 milligram, so you can assume this is 1 milligram, but this patient was quite obese. So we sometimes just do the 2 milligram testing. Anybody who likes to comment on these tests? You can send them privately to me if you want. And I'll just share the opinions without sharing the personal details if somebody is. Okay. Keep it simple, guys. مريض عنده chronic kidney disease واحدة. رقم 2 عنده hyperaldosteronism. ما يراد لها روح القاضي بين ذي شيء. Okay. And third, his DHEAS is on the lower side. ACTH is normal, but also on the lower side. Well, 1 milligram dexamethasone suppression test 2.6. والnormal تتوقع لازم less than 1.8. عاشت ايدك. بالضبط. Very good. Excellent, Shabab. Excellent. Now you're starting to understand the dynamics. This patient, on the top of having hyperaldosteronism, has unsuppressed cortisol after 2 milligram or 1 milligram dexamethasone, which means that there is some autonomous cortisol secretion, as well as hyperaldosteronism. How do we know this? DHEAS on the lower side, طبعا اكو ratio احنا نقسم ال DHEAS level على lower end of the DHEAS for that patient. But generally, if it is on the lower half, lower side, I can suspect that there is some autonomous cortisol secretion going on. ال 1 milligram DST مالته 2.6, it should be less than 1.8. معناته اكو autonomous cortisol secretion. يعني هذا يعتبر positive screening test for Cushing، بس هو ما عنده frank Cushing، ونسوي 24 hour cortisol يطلع normal. ايش راح نسوي؟ احد الزملاء اقترح imaging. السؤال قبل هذا لازم دائما نسأل، نحتاج نسوي confirmatory testing لو لا هذا المريض؟ Do we need to do a confirmatory testing or not in this patient؟ يعني نحتاج نسوي saline suppression لو لا؟ If you just can answer me with yes or no on the chat, I'd really appreciate it. No, no, good. أحد يقول yes. أحد الزملاء suggest high dose dexamethasone suppression testing. Okay, reasonable. So Sardar, Muhammad Sardar, why would you want to do a high DST? Can I ask what is the rationale? أنت عندك ال ACTH is 12 now.
Thank
So
you.
yes.
Thank you, Dr. Araz.
Yeah.
I have to differentiate or discriminate between the autonomous ACTH from the pituitary ACTH, and could be helpful because we don't know whether this adenoma is functional or not. Maybe the high blood pressure is coming from the ACTH.
Sure. So very, very reasonable, Dr. Sardar. It's one of the things that people do in the United States. I know that UpToDate recommends this, but this is not the practice here. The rationale is this: we have an autonomous cortisol, we have an unsuppressible cortisol after 1 milligram DST. You want to make sure that this is not coming from the pituitary, right? When you look at the ACTH is 12, it's in the lower end, so we know that it's probably query, it's less than 15. It's unlikely to be ACTH dependent. 2 milligram DST is unsuppressible. Now, in the United States, they do the same as you do. I don't have any issue with that. They do the 8 milligram dexamethasone suppression testing to make sure that it is not pituitary, because if you give 1, you give 2, you give 4, you give 8, it's not going to suppress the autonomous cortisol secretion from the adrenal glands. So that's the rationale. The problem is 8 milligram dexamethasone suppression testing requires the patient to come into the hospital here in the UK. You cannot do it as an outpatient, or you cannot perform the high dose DST as an outpatient for safety reasons, because people can have developed, they have some issues with people developing acute psychosis or severe hyperglycemia. So it has to be done as an inpatient, which is a bit not easy always, unless you have a dedicated endocrine ward. But it is one of the things that definitely you can do. I agree with that, to see if there is any evidence of ACTH dependent hypercortisolism. In most of these, you'll also, in any cases of autonomous cortisol secretion, you have to do 24 hours. Now, we agree that this patient does not require AVS, and I'm very happy that you all agree that this is the protocol. And this is based on the fact that his aldosterone is more than 21, more than 20. Now, what do you want to do next? I think somebody suggested a CT scan. Good. So let's see what the CT scan showed. So this is the CT scan. So what do we have? As you can see, so we have two adenomas. One of them here, this is the right side, this is the liver, as you can see. It is a lipid rich. How do we know this is lipid rich? From the house field, it is minus 1.9. It means it's lipid rich, and you can just know by experience sometimes. This is a non-contrast CT. Guys, I'm sorry, I haven't emphasized on this. When you are screening hyperaldo, please don't do a contrast study. It's useless. Do a non-contrast study and ask the radiologist to report the house field unit. So as you can see here, very clearly, there's a hypodensa. You can just compare it to the fat here. It's very close to it. And if you measure the house field unit, it is minus 1.9. So this is a lipid-rich adenoma on the right side, 1.2 by 1.6. And on the left side, you see another nodule here. This is your kidney, guys. So there's another nodule here that is almost the same as the spleen, almost the same density as the spleen. So this is a lipid poor adenoma, 22.2, and you're always anxious about these. You're always anxious about these. 1 centimeter on the left side. So what do you want to do now? How would you advise? You have two adenomas, one on the right, one on the left. One of them is a bit suspicious. So just for you to know, generally, if the house field unit is more than 20, there is a risk of ACC or adrenocortical carcinoma. So what will you advise in this stage? Okay, Dr. Araz mentions adrenal venous sampling. Fair enough. So if you want to do the adrenal venous sampling, it will tell you if the cortisol is coming from the right or the left. Okay, while adenoma here, there is a suspicion of malignancy or something else. What are you going to do about it? It's not easy, but I just want to push you, to stimulate you, to see what you think. This is a case that comes to you and now is saying, يقول لك يا بالجراح قال لي دكتور أشيل لك اليسرى. قال لك أشيل اليسرى لأن اليسرى هاي مخوفتني, which is fair enough. But so Zaid suggested a PET scan, very reasonable. I'm very happy with that. But if you don't have a metomidate PET scan, it will be a bit tricky. There is something that is more important at this stage. PET scan is very reasonable. I'm very happy with this decision. Very practical. You know, if the PET scan is strongly positive, حتى ال FDG PET, at least it will tell you that you need to remove one of the adenomas. فإذا طلعت هي أم الهايبرالدوستيرونيزم كان بها، إذا ما طلعت تبقي على ميديكال تريتمنت، فما شيل اثنيناتهم ما يصير. بس على الأقل أنت تشيل اللي هي suspicious on the PET scan اللي هي عادة ال left side. Any other suggestion, guys? ماكو. Left adrenectomy. Fair enough. المشكلة يعني it looks homogeneous. So like all of the cases with house field unit of more than 20, you need to have a multidisciplinary meeting before deciding. And the general strategy before advice, there is no clear features of malignancy. For example, cystic changes, enlarging size or size more than 4. The general strategy would be to monitor them at least after 3 to 6 months, see if there is any interval change. If it is growing, then yes, you would go for surgery. But up front, it's not clear And you might want, can I suggest, you might need to do one test before you do the surgery on this gentleman. Remember, he has he's hypertensive, and he has a lipid poor. Very good. Oh, thank you very much. We need to screen for FeO in any nodule that is more than a Housefield of more than 10, and particularly if the Housefield unit is more than 20, before sticking any needle, before doing any surgery, because this could be a very small pheochromocytoma. Okay, it might look like this, but if you see it in a few years' time, it will become large, ugly, like cancer. But every pheo starts like a small nodule. So I guess the learning point is we need to make sure that if you have an adenoma with a Housefield unit of more than 20, I don't care what was your initial screening for this, why you requested that CT scan for. You might have requested that CT scan for headache. I don't care. People do CT abdomen for headaches now. But if you have a Housefield unit of more than 20 or more than 10, but particularly more than 20, you have to screen for pheochromocytoma. Okay, this is very, very important. And you have to screen any adenoma, right, left, higher Housefield unit, low Housefield unit, with with 1 milligram dexamethasone suppression testing. And if the BMI is more than 40, probably do 2 milligram DST to avoid false positive testing. Good, so very good. 24-hour urinary methanoephrine was normal in this gentleman, and the procedure was, the next step was adrenal venous sampling, and you will see the results next. شنو الادرينال venous sampling? Dr. Ghalid will usually the Housefield units are not mentioned on the CT report. Yes, but you can ask them. If you go to the radiologist and ask them, they can actually just put a marker and they will give you that. But you have to ask for them. And if you request the CT scan, and even in Baghdad, and you request it from professional, experienced radiologist with the request that this patient has been worked up for this or that, they will definitely report the Housefield unit. Now, one caveat, guys, with the Housefield units, you have to remember this. If the mass is heterogeneous, it is probably useless. That's important. If the mass is heterogeneous, which means that it's not homogeneous, one part is hyperdense, one part is hypodense, then the Housefield unit will become less reliable in these cases. We come to the adrenal venous sampling. I have a few cases prepared, but probably for next session. But for today, I just want to give you an idea. What we do is we measure the aldosterone in the right adrenal vein, the left adrenal vein, and then in the inferior vena cava. We measure the cortisol as well, right, left, and IVC. And then we correct the aldosterone to cortisol. This is very important because you need to understand that the left adrenal vein comes directly sometimes, so you have to normalize it for the cortisol, or else you will not be able to interpret well. There will be some dilution sometimes from the renal vein. So the ratio is what you are concerned about, the ratio, not the absolute number. So you compare the ratio on the right to the left. And this is usually done under CRH, ACTH stimulation, synapse stimulation. You compare the ratio, as you can see here, the aldosterone to cortisol ratio on the right compared to the left, it is 24.6 to 1. يعني هذا بقد هذا 24 مرة. وإذا أكثر من 3 أو 4 يعتبر positive test. يعني أنت أكو dominant production of cortisol of aldosterone from the left side. هسه ممكن قائل يسأل يقول مو هاي مو عندي cortisol أيضا over production، وإذا عندي over production of cortisol from the adenoma it will interfere with ratio. Absolutely correct, absolutely valid point. But the problem is we have data to support that if the patient has mild autonomous cortisol, mild, not frank hypercortisolism, then this will not affect the ratios. Now, if this patient, if this same patient had only one nodule and some hyperaldosteronism with aldosterone less than 30, with autonomous cortisol secretion, you can go ahead and do the adrenalectomy right away without needing the ABS, because usually cortisol is size dependent, because this adenoma is probably producing cortisol anyway. It's controversial, but this is some of the things you can consider to do. So going back to this ABS here, as you can see. So I know from this that definitely the ratio on the left is higher than the right. نرجع مثل ما قال الدكتور سردار مشكورا، يعني انه left adrenalectomy was the correct choice. عمود ارتاح كي يرتاح قلبي وارتاح انا نفسيا. I compare the aldosterone cortisol ratio between the right and the IVC. اقارن بين اللور سايد والاي في سي. مثل ما تشوفون انه الالدوستيرون كورتيزول ريشيو اعلى بالانفيرير فينا كيفا مما هو بالرايت. فشنو معناته؟ معناته اني الالدوستيرون برودكشن بالرايت سبرست. ليش؟ لان عندي اكسس الدوستيرون دي يجيني من اللفت سايد. هذا نسميه contralateral suppression, which is very useful. Sometimes the cannulation is very difficult on the right. لكن if you have a contralateral suppression، يعني إذا أنت عندك proof إنه ال other adrenals is suppressed، شلون تعرف proof؟ You compare the AC ratio ذيك الادرينال لل IVC. If it is less than the IVC, usually 1, it means that there is less aldosterone produced from that adrenal gland. معناته this gland is suppressed by the excess aldosterone coming from the other adrenal gland. And this is another reassuring thing that the aldosterone in this case is coming from the left adrenal gland. So more than happy to proceed with adrenalectomy in this case. So this is the image, as you can see here. Now, one of the things that you would consider in this case is you need to cover the patient with steroids. Can anybody suggest why? Or maybe you don't. Do we need to put the patient on hydrocortisone or not? What do you think? Yes. Why? Because we have autonomous cortisol secretion from the adenoma that we will probably remove. And the other adrenal might be suppressed by that autonomous cortisol secretion. So the patient might end up with hypocortisolism after the operation. So you need to put on some steroid and you just taper it quickly and then stop it. Now, plasma aldosterone concentration was less than 4 in this case. It is very important to realize if you treat hyperaldosteronism, both medically or surgically, the kidney function will get worse if the patient has chronic kidney disease. And you might have rebound hyperkalemia in the early phase following the surgery. So we need to monitor the potassium very closely, because you get rebound hyperkalemia, which is usually an indicator that you remove the right gland, and it's an indicator of hypoaldosteronism. But declining GFR is one of the things that can happen, and you should expect it to happen, and it's unlikely to recover. And this happens because when you have hyperaldosteronism, you have high glomerular filtration. When you remove the hyperaldosteronism, this will affect the kidney perfusion. Ultimately, you will get the kidney function to drop back to its real function. And that's why you get chronic kidney disease. Despite this deterioration, on the long run, you will have less deterioration towards dialysis. And this is one of the roles that we treat hyperaldosteronism, to prevent the patient from reaching dialysis. Now, 2 years post-operatively, blood pressure still required 10 milligram of amlodipine, carvedilol, and hydralazine. So somebody would say, why did we even bother with this? Because hyperaldosteronism is not only a blood pressure disease. It is a kidney disease, it's a heart disease, it is a stroke disease. We know that patients who undergo surgery have better quality of life than patients who are medically treated, although the data can come from a pool of patients who were treated with spironolactone, but they were not monitored by the renin, as we will see next. So maybe they were not optimally treated, I don't know. But generally, we know that patients who undergo surgery do better. And that's why we treat hyperaldosteronism. Now, following this, we did 1 milligram DST test, which was negative. CKD was found as a confounder or as a complication. Now, the drop in the GFR probably means it's one of the complications, unlikely to be a confounder. And this is basically due to long-term hypertension from secondary hyperaldosteronism. It wouldn't change much, but it will change this. Evidence clearly says that patients who have hyperaldosteronism for shorter duration, less than 5 years, compared to those who have it more than 10 years, they do worse after the surgery and unlikely to be cured by surgery. Those who have chronic kidney disease to start with before the surgery will unlikely to have normalization of the blood pressure without antihypertensive medications after the surgery. It's one of the poor prognostic features to predict cure in these patients. Now I'll end up with what is the state of the art modalities in the treatment of medical treatment of hyperaldosteronism. Say you have bilateral adrenal masses, you don't have ABS, PET was negative, you don't know what to do, you decided to put the patient on medical therapy, or the patient doesn't want surgery or unfit for surgery. Now, first-line treatment. So this slide actually covers the treatment options we have. So what we do is, number one here, as you can see, we need to restrict sodium. Very, very importantly, commonly missed in these patients. These patients crave salt. You need to understand this from the hyperaldo effect on the CNS. They eat a lot of salt. We have to let them know they have to cut down their salt intake, very, very importantly. And it affects and there is a sodium calculator you can use to estimate your salt intake. Most of these patients have at least 10 grams, which is far too much than what they should. The second thing we use here, mineralocorticoid receptor antagonist, which is the spironolactone or the eplerenone. We start with a small dose, 25 milligram. Most of these will respond to very small doses. You need to keep an eye on their GFR and UNE. Don't be discouraged by the drop in GFR after a spironolactone. This will happen, and it's not a problem. And you can optimize the dose gradually, aiming for how do I increase the dose? كل أسبوع 10 أيام أسبوعين you can increase the spironolactone to a dose of up to 150, maybe 100, 150. Although most of these patients, they don't need these higher doses, but up to this dose. But you titrate it based on what, Sean? عندي renin, I measure the renin. ما عندي renin, I have to follow the potassium. I usually aim for a potassium more than 4 to 4.5. But ideally, you would want to check the renin in these patients to make sure that the renin is unsuppressed or desuppressed. If you unsuppress the renin, you're doing well. Do we follow the aldosterone levels? No, we don't, because we're blocking the aldosterone, as you can see here. There is no sense in measuring the aldosterone levels unless, so before I go to the fourth step, if you have reached the highest dose, or if the patient develops side effects with the higher dose, especially in male painful gynecomastia, you can use a eplerenone. But if the patient cannot tolerate more spiro, then you can use amiloride, which is an excellent drug in these patients. Amiloride is an excellent drug because, as you can see, it blocks the channel itself, so it has an additive effect. What about ACE inhibitors? I don't like them a lot in these patients because they work by reducing the aldosterone synthesis, and in these patients, the aldosterone synthesis is already spontaneous, so they don't work a lot. But calcium channel blockers, especially the dihydropyridines, they work very well. So these are the drugs. Beta blockers also work, but these are the drugs you want to consider when you are approaching the treatment of patients with the primary hyperaldosteronism. especially sometimes you don't have a formal diagnosis, you have resistant hypertension. So these are the things that you need to consider. Combining sometimes, especially if the potassium allows. Now, most recently, and there is work on the aldosterone synthetase inhibitor, CYP11 beta 2 inhibitor, which is one of the medications to reduce aldosterone synthesis from deoxycorticosterone. It's not on the market yet. So by this, I have finished my presentation. Inshallah, we will have a next session. We will discuss more complicated hyperaldo. This was just an introduction. We'll maybe, if you are interested, we can do more AVS scenarios, but only if you are interested, because I know this might be beyond the scope for general physician, and especially it is not widely available. Patients have to go to Lebanon. Ma'arif Dr. Sardar might give them information. He might be up to date if there's any AVS been done in Kurdistan. But as far as I know, it's not yet available in Iraq. Unfortunately, now this is done usually by interventional radiologists, and our role as endocrinologists, whether it's in the IPSS or the AVS, is to interpret these findings, not to do these tests. If you are interested, we can proceed, but I think I have covered the most important aspects with regards to the general physician. When to suspect it, how to screen for it مثل ما قلنا. aldosterone renin, aldo أكثر من 10, renin أقل من 8, DRC. This is hyperaldo. Line suppression testing or imaging will guide us through the treatment. Medical treatment خاصة من ناحية الphysician. Spironolactone, amiloride, calcium channel blockers. Unfortunately, yes, it is not available in Erbil. But hopefully it will. Now, hopefully the PET scan would be the next step. If we can get the mitomidate actually widely available, because PET scan is available in Iraq. If we can get the mitomidate, this is the better alternative now. Everybody is moving into that direction now. So any question, guys? Any questions? I wait for your feedback, whether you want us to proceed for the PHEOs, the Cushing's, the adrenal masses, or you want us to continue with the hyperaldo for another session. If you screen for hyperaldo a lot, in every clinic, now I have 3 or 4 patients out of 10 patients who have hyperaldo. It's very common if you screen for it. Thanks very much, guys. I'll wait for
عفوا
feedback.
دكتور.
اي يعني تفضل.
دكتور رافد يسأل من داية if the ACE and Arabs have any effect on the testing of aldosterone and renin.
Theoretically, yes. Classically, the guidelines would yes, you have to stop them. Practically, no. And most of the experts, they don't stop them. Like if you have a high suspicion and the test is borderline showing a renin, مثل ما قلت أول شيء I will do the test. If the renin is high, more than 8, and the aldosterone is high, and I still suspect that this patient might have hyperaldosteronism, I will stop them, of course, because they interfere with the assay by reducing the aldosterone. لأنه شلون تشتغل هي الانجيوتنسين converting enzymes أو angiotensin receptor blocker. تشتغل على الانجيوتنسين 1 الانجيوتنسين 2 مو مهم. الانجيوتنسين 2 راح يروح على الادرينال يزيد لك الالدوستيرون. if you block it you will have less aldosterone. هذا المشكله. فمن تجي تحسب الريشيو ممكن الريشيو مال الالدوستيرون تو رينين تكون falsely low وانت عاد متوقعها هاي. فهذا السبب انه عاده نحاول انه we repeat the test after stopping the ACE or Arabs for at least 2 weeks. Not, I don't stop them generally. But you can see some references who suggest to stop them. أي سؤال ثاني؟ ترى غادة تريد تكمل ويا الهايبر أردن. أوكي إن شاء الله. إن شاء الله أسبوعين إذا الله سهل أسبوعين أو 3 إن شاء الله. أنا الجمعة شوية بين جمعة وجمعة عندي استشارية مال دايابيتس العصر، فمو دائما عندي مجال، بس إن شاء الله نحاول نرتبها خلال أسبوعين 3 نكمل ويا الهايبر ألدوستيرون. شوية نسوي تقوية للهايبر ألدو. For me actually it's very important that you are very much comfortable and in screening and interpreting the initial results of hyperaldosteronism. You know, it's very common in hypertension. It's not like the FIOs, it's not like the Cushing. These are more of interest to the endocrinologist, not to the general physician. But I think hyperaldosteronism should be done by every screening by every physician who sees patients with hypertension, whether cardiology or just even general physicians. Thank you so much for attending. Thank you so much for contributing, especially دكتور محمد سردار وأستاذنا أستاذ رافد الطويل وزملائنا دكتور زيد دكتورة غادة وباقي الزملاء. اعذروني إذا مثلا نسيت أحد. We're looking forward to seeing you in the upcoming sessions إن شاء الله. مع السلامة.
شكرا جزيلا أستاذ. مع السلامة.
مع السلامة.